Well, thank you very much for the invitation today to speak. I'm going to be speaking today on the haves and have-nots, specifically barriers to access systemic treatment across healthcare systems. These are my disclosures. None of them are relevant to today's discussion, but this lists all the different pharmaceutical companies whose trials I conduct, advisory boards that I sit on, and honoraria that I've received over the last 5 years. So I have two main objectives of my lecture today. First, I'm going to be providing an overview of the global burden of lung cancer. And then the majority of my talk is going to be focusing on the reasons for inability to access cancer systemic treatment. And I'm going to break it into three different themes. I'm going to talk about accessibility, availability, and affordability. So this is a breakdown of the global lung cancer incidence and mortality, and this is the most recent statistics. And if we look at the breakdown with both of the sexes combined, actually with this most recent iteration, breast cancer just surpassed lung cancer as the most commonly diagnosed cancer on the planet. So it's now 11.4% of all new cancer diagnoses are going to be a lung cancer diagnosis. But unfortunately, we have not been unseated as the number one cancer killer. So if we look at mortality, 18% of all cancer deaths are going to be due to lung cancer. That sums up to 1.8 million people on our planet every single year dying because of lung cancer. Now, if we look at the breakdown by sex, you'll see that in men, lung cancer is both the most prevalently diagnosed cancer, but also the biggest cancer killer, so it goes hand in hand. If you look at women, though, you're going to see breast cancer takes the stage as the number one cancer that's diagnosed, as well as the number one cancer killer. If we look at the actual distribution, sort of on a global stage, you can see here in men, lung cancer rules the world, unfortunately. So if you're looking at Canada, US, most of South America, all of Asia and Europe, Australia, and then fractions of Africa. If you look, though, at female sex, again, the unfortunate part of privilege, right? So Canada, US, China, and significant chunks of Europe. Lung cancer actually trumps breast cancer as the most common cancer. And across the board, lung cancer is the highest risk of cancer death. So let's focus in on why things are so bad. And part of it is inability to access systemic care in general. Now, there's inability to access all sorts of care. My focus is really on systemic. But there's multiple aspects of why this is a struggle. So I'm going to focus in on, again, three themes: accessibility, availability, and affordability. I would be remiss before embarking upon a talk where I'm going to talk about every MIB and MAB and TKI and systemic chemotherapy if I didn't show this slide. I would imagine that every clinician in this room provides some level of palliative care to patients. And one of the mainstays of palliative care provision is ability to control pain. And usually the ability to control pain is based in opiates. I found this graphic to be quite stark. This is looking at the distribution of opiate use in comparison to need that is met in different countries. And you can see the US actually uses 3,000 times the amount of opiates in contrast to what would be considered need. Canada is not far behind, again, just over 3,000%. Australia, also huge user of opiates at around 1,800%. But all those skinny little countries are ones where there's actually a disproportionate unavailability of things like morphine or opioid equivalents to be able to treat cancer pain. So I just feel like this is a moment where you need to pause and think, gosh, who cares about platinum? Who cares about immunotherapy? Who cares about targeted therapy if I can't even palliate someone's discomfort in their hours of need? So when I think about accessibility, there's lots of things that we already know. So for example, one, cancer treatment centers exist in most countries. So there is cancer therapy available across most of the planet. But if you focus in on low and middle income countries, these really seem to focus their care into urban areas. So they've got a centralized model of care delivery as opposed to what we have, for example, in Canada, which is by and large a decentralized model where you're able to get your cancer treatment generally closer to home. They've been able to show, even in wealthy countries like the United States, that there's a worse prognosis for patients who live more than 50 miles or an hour's drive to receive treatment. They're more likely to have a higher advanced diagnosis. And that has nothing to do with whether or not they're from a rural center or not. That's above and beyond rurality. It has to do with literally how long it takes you to be able to get to your cancer treatment. So one of the other struggles is there are places in this world where obviously people don't get treatment. Many patients in low and middle income countries do not receive treatment secondary to decreased access to cancer care on multiple levels. And we can't forget alternate treatments. So cancer treatment regimens vary based on geographic area within the same country, secondary to healthcare availability and resource allocation. I actually remember very, very vividly doing international second opinions while I was still working at Johns Hopkins back in the late 2000s. And so people would send me their records and I would review them and provide them written advice without ever actually necessarily seeing the patient, but based on chart review. And I still remember reviewing a chart of a woman who'd had a lung cancer. She had had chemotherapy and radiation. And she now had a new tumor growing sort of in the radiation field. And the local team had advised her that she didn't need a biopsy, that this was likely her lung cancer coming back, even though it was 5 years later. But what was very subtly buried in the documents is this woman actually had received cobalt radiation as opposed to the fancy modern day radiation that we receive. And those of you who work in the radiation oncology field will know that cobalt carries a much higher risk of secondary malignancies, et cetera, et cetera. And you think this might be from, a place in Africa or the like. This was from the Atlantic provinces. This was somebody who was treated in the 2000s in the Atlantic provinces. So this is not just something that happens, in places that you have to take a plane or cross an ocean or things like that. This actually happens within our own country. So one of the hard parts about delivering cancer care on this planet is to actually get systemic treatment. You have to have a diagnosis. That isn't necessarily true for surgery. That isn't necessarily true for radiation. Lots of surgeons take things out without actually doing a biopsy first. If it looks like cancer, they will go ahead and make the presumption it's cancer. We do this in radiation, actually not infrequently. Someone may be high risk for a biopsy. PET scan might be positive. CAT scan has speculations. We're going to go ahead and treat that with stereotactic radiation without actually putting the patient through the risk of a biopsy. But I'm not familiar with any medical oncologists who are willing to stick their necks out and actually give somebody intravenous systemic therapy without a tissue diagnosis of some sort. So if you're going to get systemic therapy, you have to have had a procedure to actually get a diagnosis. And then a whole nother leap above and beyond that is actually not just a diagnosis, but a full molecular characterization. So when we're treating lung cancer, we are stuck dealing with these tiny little specimens. And I have to take my hat off to every pathologist who looks at lung cancer specimens, because man, do those people work with the tiniest little bits of tissue and get me these huge volumes of information. And it's partly because we're smart, right? So they use their eyeballs and they try to see if they can figure it out just based on morphology. If they can figure it on morphology, order molecular testing and move on. If they can't, then they use limited immunohistochemistry and then move on to molecular testing. But this all requires the infrastructure to do all these different things. So when we think about molecular testing, part of the issues with access is issues not only of access, but awareness. So this was actually a survey that was done by the International Association for the Study of Lung Cancer, and they surveyed pathologists from across the planet back in 2020, looking at what was impacting in their part of the world their ability to access molecular testing. And you can see they broke down the data by two different categorizations, one by region of the world and then one by economic status. And so if you look, you can see there's actually variability on why molecular testing may or may not be available. And it's fascinating at how much it factors on people don't even realize, like they don't have what I call de-differentiated pathologists, right? If you've got a pathologist who has to look at every single, both non-cancer as well as cancer diagnosis, they may not be able to keep up with the latest and greatest of all the little buzz tests that we need done. It's also ability to actually have the tests, right? And we've been dealing with that in Canada, not to mention in other parts of the world, where it's only been in 2022 that routine access to things like next generation sequencing for lung cancer has become readily available. And again, we're a have, we are not a have not. If you look at barriers by economic status, you can see cost is a problem no matter whether you're in the developing or the developed world, but you can also see quality of testing is less so they don't have the fanciest of instruments, the fanciest of technology. But again, access is a bigger problem as well as awareness. So what types of factors actually impact that uptake of biomarker testing? So one is access to pathology. And I'd mentioned a little bit about centralized versus decentralized models of cancer care delivery. And that's true for pathology as well. Actually, I hate to say it, like Hamilton is a centralized system, and it actually creates us heartaches and headaches. It takes me on average 2 to 3 times longer to get a full molecular diagnosis of a patient if I biopsy them at the cancer center hospital than it does if I send them through the lung diagnostic assessment program, where we have a group of pathologists who are interested in lung cancer, and they do things in that expedited algorithm that I described. And again, we're a have. You can imagine how difficult it is if you have to actually ship your specimens off to other places. But that may actually be a cost-effective model to allow for these different centers to be able to do what we need them to do. The struggle with decentralized models is it's more cost for resource, right? If you have to have, a immunohistochemistry processing machine and the paraffin machines and all this kind of stuff in every single hospital, it costs more per test rather than having things centralized. Then you have to deal with the timing of the shipping and the human power to get things moving around, but it actually costs less per test to have a centralized model versus a decentralized model. Many places don't have adequate on-site testing facilities, especially in your low and middle income countries. And again, around 40% are the ones who actually just outsource everything completely. They have no access to the pathology or the molecular testing within their own hospital. If you look at the variability of access to testing, it's actually quite striking. Some countries, it's as low as 7% of new cancer diagnoses get molecular testing, or as high as 85%. This is specifically about lung cancer. That's a huge range of what we would expect. Part of the other issue is that sometimes it all has to do with what type of specimen you get. Again, you can imagine we are a place of privilege. We have access to amazing interventional radiologists, CT scans, where we can do guided biopsies and actually get multiple passes and cores of tissue. Whereas in other places of the world, the best you're going to get is you're going to get a bronchoscopy and some brushings and washings, and you're going to have to use that to actually get all the different things that you need. And when we looked at our data in Hamilton, if you were working with that type of specimen where it was brushings, washings, those types of things, 1 in 4 did not have enough tissue to actually even make anything beyond a molecular, just a general histologic diagnosis or cytologic diagnosis, as I should say. We also have to prioritize based on what we know. It's very interesting in lung cancer. For those of you who don't treat lung cancer, there's actually very different distributions of the different molecular subtypes of lung cancer. That's true in Canada, that's true globally. If you look at what we see in Hamilton, we're actually very similar to what happens in Quebec. Very blue collar, very smoking driven space for lung cancer. If you go out to my colleagues though in Vancouver, right, they have a huge Asian influence, a much higher rate of these driver mutant lung cancers. Toronto's a whole mix, right? There's certain areas where you're going to see higher rates of driver mutants and certain other areas where you're going to see higher rates of smoking related cancers. So you kind of have to know what your general gist is of your patient population to get the biggest bang for your buck. So let's talk about availability. And this cartoon kills me because I feel like I am constantly being asked to get blood from a stone when it comes to finding money to do all the things that I want to do. But availability is a struggle. So this is just a graphic looking at some of the recent systemic approvals in lung cancer, focusing on the EMA as well as the United States. And you can say we are making big progress in systemic therapy in lung cancer. Across the top are different immunotherapies, either single agent or in combination. And across the bottom are recent approvals in targeted therapies. Well, let's talk about just again, our backyard. That's what we actually have funded in Canada, in contrast to our peer nations, right? We've got a few different immunotherapies, some single, some in combination with chemo. We only have a handful of targeted agents. So we have to be mindful that even in the wealthiest of countries, there's going to be disparities. So I'm going to talk a lot in this next section about the World Health Organization Essential Medication List. So this is a listing that is curated by the World Health Organization in an effort to keep a standard for what is considered required or recommended, I should say, for countries to provide for their people. So the first list was actually back in 1977. And at that point, we didn't have a heck of a lot. So there were only 6 cancer medicines that reached the bar of making the essential medicines list. You fast forward to 2015. This was the first time something that was on patent made it to the list. You can imagine on patent equates to cha-ching, cha-ching, cha-ching. These are much more expensive agents. This is the first time that we saw big enough bang for the buck to actually have patented medicines make their way to the list. 2021 was the most recent version of the list, and you can see there are 62 cancer medicines in total, some of which have overlapping indications. There was 3 new ones as well as a new indication for a pediatric cancer malignancy. So this is their prioritization schema for how agents are looked at. And you can see here, if there's palliative indication, depending on what the benefit is, from low incidence to high incidence, and then all the way up to cure, you can see different diseases that they focus their efforts on. So cure or near cure is your heme malignancies, your germ cell tumors, and then early stage cancers like breast and colon, which are huge numbers out there of new diagnoses. You can also see that there's data in here on things like metastatic breast cancer, metastatic prostate cancer. What don't you see? The #1 cancer killer on this planet is not part of the framework for them to consider new access to drugs as part of that WHO list. How do they select medications for this list? So they've actually adopted the ESMO, the European Society of Medical Oncology, magnitude of clinical benefit scale as part of their algorithm for looking at drugs. They've got different schema depending on if it's a curative intent space or if it's a metastatic space. And so you can see a score of an A or B is required if you're in the curative intent setting, or a 4 or a 5 in the non-curative intent setting. If you're going to actually get not listed, but an evaluation to be listed on that EML. Now, this is the bar they're looking for. So this is not your ASCO, oral abstract where you improve the survival by 4 weeks, 6 weeks, 8 weeks. It requires at a minimum 4 months, preferably 6 months of overall survival gain, but not only overall survival gain without detriment to quality of life. So they actually look both at quantity, but they have to see that it's not in consequence to quality. So if we look at how good are countries at being able to access the medications on that essential medicine list, this is a map. This is not a cancer-specific map. This is a map in general that speaks to access. And you can see, again, we're a have, right? Canada, the United States, Australia, Europe, they are have countries where they have the vast majority of the agents. So less than 100 agents are not listed in those countries. But if you look at other parts of the world, right? So if you look at, say, Russia, right? They don't have 500 of the medications that are on the list. If you look at Mexico, they don't have 500 of the medications on this list. And these are not countries without means, right? They are not the wealthy, but they are not without means, but yet they do not have access to half of the medications on the list. So if we look at access to WHO essential cancer drugs, we can look at this graphic that actually demonstrates breakdown by what's considered a high income country, an upper middle income country, a lower middle income country, and then a low income country. And you can see high income countries of the top 20 essential cancer drugs, they have all of them, right? If you're looking at upper middle income or lower middle income, they have most of them, 18 and 19. But if you're a low income country, they have less than half of the agents that are considered essential medications for cancer treatment. If I focus in again on my disease site, lung cancer, these are the drugs that make the list, right? This is the stuff that I was using when I was first in practice, and I've been in practice now since 2004. So it's platinum, it's a couple of the adjuncts, etoposide, gem, taxane, vinorelbine, and then one targeted agent made it. Note it is the old off-patent agents like gefitinib or erlotinib, specifically for EGFR mutated lung cancer. So I found this fascinating. So this is a footnote in that WHO EML briefing. These are the listings of cancer drugs that are specific to lung cancer that were actually attempted to get added to the list and were rejected. So you see all four of the big players in immuno-oncology, and then you see osimertinib, the darling of ASCO this year. So when they say why, this is why. PD-1, PD-L1 immune checkpoint inhibitors were not recommended for the treatment of any number of lung cancers, despite their acknowledgement that these are highly effective drugs, because the price point is too high. These drugs are not available at different price differentials for different countries. There's no means to pay, et cetera, et cetera. And the toxicities are tricky to manage if you don't have resources, right? Again, I'm a lucky lady, right? I can phone up innumerable numbers of friends if I've got somebody who's got an immunotherapy toxicity. If you don't have friends on your, I was going to say Rolodex, I'm making myself sound really, really old. If you don't have friends on your contact list on your phone, you know, you're going to have to figure these things out on your very little own, and people may die of toxicities that they don't otherwise need to. Same issues with drugs like osimertinib. To make me feel not so bad, I left in the entire paragraph because I do want to drag down my breast cancer colleagues as well. So osimertinib, the different CDK4/6 inhibitors, fulvestrant and pertuzumab were also considered too high a price for the benefits that they provide. So they were delisted from the consideration. So this was a wonderful survey that was done. It's just shy of 1,000 global medical oncologists were surveyed across 82 countries. And all we were asking was whether or not your patients could access these different drugs. And again, this is mind-blowing for me. So you'll see on the far right, high income countries, in the middle, upper middle income countries, and then on the left, low and lower middle income countries. And you can see different essential medications that were listed. If we look at, again, what's out there, it's chemotherapies when it comes to lung cancer. So you see across the board, platinum, taxane, gemcitabine, etoposide. But the thing that blows my mind is even in high income countries, only 50% of them had access to platinum, right? I would have never even thought platinum would be something that was not readily available, but yet it is not necessarily readily available across all these different countries. If we look at targeted therapies, again, most folks consider osimertinib an essential medication, and that makes the list. Gefitinib was considered an essential medication here. And then you start to see immunotherapies, right? And which ones are considered most heavily prioritized. So next I'm going to focus on not just access, but when we can access. And this is something near and dear to my heart. This is a graphic actually looking at countries across the globe. So you'll see the US, the European Union, Japan, Israel, Korea, et cetera. And this is looking at when the indication actually came into place and then when subsequent approvals actually came around. And you can see here that there's huge delays in other countries beyond basically the United States, with the exception of 2 drugs where Japan actually got the first bite at the apple, but by 2 months for lorlatinib and by 3 months for alectinib. But otherwise, the US got first crack at an approval for every single new cancer drug. And if you look at what the delay was across these different jurisdictions, it sits anywhere between 11 months and 14 and a half months, depending on where you're at. If we look at the Canadian example, this is a publication by one of my colleagues, the senior author is Paul Wheatley-Price from Ottawa. And this looks at how long did it take from when we knew the drug was efficacious to when we actually had a submission to our health technology assessment to when there was actually public funding. And then some of the most egregious of them all, you can see that it was 5 years from when we had our actual indication for these drugs being shown as efficacious to when Canadian patients could actually access them. So they went one step further, not only looking at how long did it take, but then they went back and actually calculated how many patients were dying because they couldn't access these drugs. And so they broke it down by progression-free survival as well as overall survival and looked at the life years lost between those time points of us knowing that the drug worked to us having the drug readily accessible. And you can see, for example, pemetrexed maintenance, 8,000 life years lost. If you're looking at immunotherapy, again, 8,000 life years lost in the amount of time it took us to get access to these drugs. This is a big deal for our Canadian patients. So if we look at affordability has multiple components to it. So first things first, again, I'm an American, probably shouldn't, I think hopefully Fabio disclosed that well enough for y'all so that you can take, I guess, anything I have to say with a grain of salt. But if you look at the United States, the largest payer for healthcare is Medicare. They are not allowed to negotiate on price. As soon as the FDA approves something, a price is listed and that's the price it's going to be. And the government doesn't negotiate at all with the pharmaceutical companies. And you wonder why the cost of healthcare is so high. The analysis of the top 10 selling cancer medicines in the United States and the UK showed that US launch prices were 42% higher than what the UK would stand for. If you looked at 31 cancer medicines across 16 European countries, Australia, and New Zealand, the range of what different countries paid, some countries paid as low as 28% of the median price, and some paid over 388% higher than the median listed price. So different countries are better at negotiating with the pharmaceutical companies when it comes to getting a good price. Again, 92% difference in the list prices for different cancer medicines across the EU. So if we look at the trend, right, we're seeing more and more drugs, and I showed this to you earlier, we're seeing more indications, more medicines every single year. And if we look at what that impacts on just the expenditure of cost, this is not looking just at cancer, this is looking at pharmaceutical expenditures in general. This is looking at what our actual GDP is. So our gross product of what, for example, Canada, 7% of Canada's money is spent on pharmaceuticals, right? Like that number dumbfounds me. It's not on schools, it's not on roads, it's not on, any of those types of things. 7% of our GDP is on drugs. So we also not only recognize that affordability is a problem, but insurance is an issue. And that speaks to the different tiers of healthcare that are available. If you look at the cost of essential medicines from that WHO list, over half of patients in low-income countries are actually bearing the cost of those drugs themselves. About a third of patients in low to middle-income countries, less than 2% of patients in upper middle-income countries actually are paying out of their own pockets for access to these agents. Other things you don't think about is many of these things are IV chemotherapeutics and don't get considered when you're thinking about targeted therapies, et cetera. So that's a Canadian problem, right? The government readily pays for any intravenous thing we want to do, but depending on what province you live in, your cancer drugs may be absolutely covered, or your drugs may actually absolutely not be covered, or they may be covered depending on what age you are, if you're under 25 or over 65 or all those types of things. So without insurance, oncology treatment is hands down unaffordable. There's not a single physician that I'm aware of that could actually sustain paying for some of the different oral therapies with the cost that they are listed at. So that's uninsured. This is underinsured, right? So if we look, this is looking at different countries, mainly across the EU, but the US, Japan, Korea, et cetera, are listed in here as well. On the left are self-administered agents. On the right are physician-administered, it's basically IV drugs to the right, oral drugs to the left, and the different financial burden depending on what the model of care delivery is. So some places, oral drugs, free of charge. Some of them have a fixed copayment that has a cap on it. Some have a fixed copayment, but there's no cap to it. Some have co-insurance with a cap, so that's Medicare, the US is listed. And then there's co-insurance with no cap. If you look at financial burden of physician-administered agents, for most jurisdictions, they're free of charge, but you can see there's also gradations to that. So again, USA. So this was, I still remember to this day, the first time I ever actually gave thought to the cost of what I did. I had no idea what a privileged space I lived in up until that moment. Again, this was 15 years ago, so it was not the fanciest of fancy drugs I had to offer. I had offered this patient pemetrexed and carboplatin. Now, pemetrexed was still on patent, so pemetrexed was still expensive at that time, thousands of dollars a dose. And this woman met with our finance team, and when she looked at what it was going to cost her for her 20% copay on her IV drugs, she was going to have to sell her home. And rather than sell her home, she opted for palliative care and no systemic treatment because she wanted to leave a legacy to her children. And she would rather die faster from her lung cancer than actually give up her home and her children's place of living. Again, who would have thought that those things happen in the world in which we live? But they absolutely happen. And so, I'd never given thought to it before. And again, I had the fortune of being healthy, and my family had the fortune of being healthy. So none of us had gone through this before. And it wasn't until I sat through this with a patient and we ended up applying for compassionate access, which I'd never had to do before in the US, to try to get this woman cancer treatment that I felt like she deserved. So what can we do about it, right? This is why everyone is here in this room and everyone's out there online. What can we do about it, right? So one, we need to encourage things like generics and biosimilars. I'm sure you've seen in Canada now, there are multiple biosimilars that are available, and actually it's now required that people switch over to biosimilars if they are available. There's opportunities in purchasing. So for example, having a local formulary. Honestly, I'm surprised that this hasn't happened to us in immunotherapy yet. What we do, though, is pooled procurement. Again, you'd think that this is something that happens elsewhere, but every drop of things like immunotherapy are so expensive that we have figured out it's actually cheaper for us to have all of our immunotherapies, because they have a decent shelf life, drawn up and mixed at a centralized facility and then distributed to the different places so that we don't miss any drops of the immunotherapy. We also group people on certain days. So our trastuzumabs, we preferentially treat on Mondays and Tuesdays. So we have reduced wastage so that we're not losing money on our agents. We need to work on fairer prices for cancer medicines. There's a concept called value-based pricing that hinges on these things called health technology assessments. And I'm going to talk more about health technology assessments. But there's a very robust program here in Canada for doing health technology assessments. And it's something that I'm strongly involved in through my work with Lung Cancer Canada. I actually don't think any of my Kingston colleagues are part of our fight. So I'm going to guilt some people into joining me because the more people we have, the less work it is. But I think this is critically important to ensuring that the physician voice is heard when it comes to the impacts of these agents. There's opportunities for price caps where we will pay up to a certain volume. There's opportunities for tiered pricing. We've seen opportunities where the company pays for the first couple of cycles, or for example, the country pays for the first couple of cycles, and only if the patient is benefiting does the country pick up the price. Internal and external reference pricing, AKA if you don't have the availability in your own country to be able to do your own health economics, you can map to NICE, you can map to the EU, things like that to look and see how their value framework works. Differential pricing based on the country's ability to pay. I think this is really important, right? There are haves and have-nots, and it kills me to see that things like platinum are not available in every country on this planet. And then I talked a little bit about optimizing schedules for cancer medicine, reducing drug wastage, doing things like Q6 weekly dosing of certain immunotherapies, et cetera. So this really looks at this concept of why this is hard, especially if you're in a country that's a have, right? It's a big challenge for policymakers. I'll tell you, I get annoyed whenever I can't get access to a drug that I feel like I should be able to have access to. There's a huge balance. We have to think about the upfront costs, the affordability, the sustainability. What's the uncertainty around the actual benefit and the cost effectiveness? What about the cascade of indications, right? This happened with TRK inhibitors, right? When TRK inhibitors had their HTA assessment the first go round, they looked at it and said, it's economical in children and in women who have this really rare type of secretory something breast cancer. And I will tell you, I wrote the nastiest letter you ever did see on behalf of lung cancer patients. And what happened? The HTA said, well, okay, we're just going to give it to nobody. So like, I feel a little bit responsible that I stripped children of access to TRK therapy. But, why? The magnitude of benefits the same. Why is a lung cancer patient any different than a woman with breast cancer, et cetera, et cetera? Like, I'm still furious that people with melanoma get access to BRAF therapies and lung cancer patients can't because we didn't randomize and they did. So these are a big deal, the cascade of indications. How does it work when you're combining, right? So when you've got the cost of chemotherapy and then you're adding immunotherapy, is it A plus B? Or now that I'm doing two things, does it actually boil down to a cheaper price altogether? And then patient expectations of timely access. Like my heart goes out to the folks who actually are the ones who have to make all these decisions. It's really easy for me to stand up and be the angry woman who wants to have all these different things for my patients. It's very easy actually to be a patient advocate. It's very hard to say no. If we look at how do you address the uncertainty around these HTA decisions? This is just looking at how different countries do it. Some of them do a financial managed entry agreement. Some of them do it by performance metrics. Some of them create registries and actually look at what the real world evidence looks like. Some do proper post-marketing studies, et cetera, et cetera. So there are ways to gather more data. So I'm almost done here. So one of the most exciting things at ASCO last year was the announcement of this. And this is the Access to Oncology Medicines Coalition. And they have two main ambitions. One, they want to increase the availability and affordability of cancer medicines across the planet. And then two, they want to increase the capacity to actually use these medications appropriately. So they don't want to just get countries' drugs, but they want to make sure that they actually have the human resources and facilities to be able to monitor them. There's a three-partite operational plan. So they're planning on working with governments and other stakeholders in these ATOM countries to assess their needs and offer training and capacity building. They want to support generic, biosimilar, and originator manufacturers to develop, register, and supply quality assured essential medicines at affordable prices. And then last, they want to facilitate the successful use of voluntary licenses for patented medications at a significant public health importance. So this is the people who've all signed in to actually work on these very weighty topics. You can see multiple big pharmaceutical companies. You can see all sorts of agencies, including ASCO, the American Society for Clinical Pathology. There's a list that keeps going on, but you can see the big names in manufacturing cancer drugs are on here and hopefully working together to do a better job of getting these agents across. So this is my second to last slide, and this is where Roz stands up on our soapbox, and this is my call to action. I will tell you, I did not walk into my oncology career thinking, I'm going to be a patient advocate. I'm going to be good at this. I got tapped on the shoulder. I remember the exact day I got tapped on the shoulder by one of my colleagues, Paul Wheatley Price. And he said, Roz, you've got fire, you've got passion, you can help lung cancer patients in this country, and I want you to join me as a partner in advocacy. And I said no. I was really trying my words, and I said no. And he's like, you're going to regret this. Say yes. This is something you should say yes to. And I said yes. And here I am all these years later. Every single one of you has the ability to make an impact. And whether that's writing a letter, whether that is doing health technology assessments on behalf of CADETH, whether it's doing the evaluations for PCPA, there are ways to have a voice here in this country as well as globally. And again, it doesn't matter where you decide to find your voice. It can be a local voice and advocating for access to treatments in your own home, right? I write more letters complaining about access to things like, it takes me 6 weeks in Hamilton to get a PET scan. It takes me 6 weeks to get next generation sequencing in Hamilton. Some days I feel like I am a upper middle income country. And I write letters and I advocate, and people probably stop listening to me because I get up and I say, this isn't right. You can do it on a national level. You can do it through things like, again, the PCPA and CADA, or there's opportunities internationally to be able to speak to these different voices. So I want to acknowledge this talk to 3 different people. One is Dr. Michaela Febraro. She actually did her master's with me. She just graduated and took her first faculty job up in Sault Ste. Marie. She actually texted me today that she just signed the paperwork to become faculty at Northern Ontario School of Medicine. And if you want to read a really great paper authored by some really cool people, including my host here, we actually wrote a manuscript looking at systemic therapy, radiation therapy, and pathology, and the impacts globally on access to these different aspects of lung cancer care. And it was published in the ASCO educational book last year. So it's free. You can go ahead, and if you want to read more about this stuff, it's a great place to do so. I also want to thank my 2 partners in crime at Lung Cancer Canada, because like I said, didn't go looking for this, but I don't know how to get away from it now. I've totally drank the Kool-Aid when it comes to advocacy. And I don't think it will ever not be part of my world. So I just want to thank everybody for their attention, and maybe I'll stop here and I'll take questions. I can see there's like 13 notifications in the chat. So.
Okay, thank you for the.
Oh, good. It was just about me being muted originally. I was worried that I was not answering questions or something like that.
Okay, that's great. So thanks for the great presentation and bringing us to the ground and understanding there's a lot of problems that we can all try to fix or to engage. So I want to ask the floor if there's any questions, any comments, anyone wants to raise a question?
For sure. Thanks. Really important topic. So it's great to have a chance to look at this. My name is Chris Booth. I'm on here. A couple of us are actually quite involved with WHL. So I'd be curious, can you go back to that slide where you showed all the lung cancer drugs that have been approved with the different flags?
I can, maybe.
Because one of the things that we need to reconcile as a community is which drugs should we be advocating for?
Yep.
Because not all of our
Gotten
are the same. I think we've gotten ourselves into trouble with policymakers and the public by the narrative that every drug is a game changer and we need to spend 200 grand on everything. And so that's, I think, what the priorities are. So I'd just be curious to look at the lung cancer drugs that are not available.
Oh, sure.
And which ones you think are really, really important. Like, for example, one of the points is on the pemetrexed story. What's the benefit of
So
roughly, like is it PFS benefit? Is
no, it's an OS benefit. It's an OS benefit about 2-ish months, but with less toxicity. Yeah.
To speak great. But some of these things, like these have large benefits. So maybe hit next so we can see the drugs that are available in Canada.
Yep. There we go.
And then, okay, so tell us, what are some of the ones there that are not available in Canada that you really think we should have, and how useful are they?
Yeah. So part of it, no. I think part of the struggle that I have is, one, companies that don't come, right? So for example, there are Me Too stuff on here, right? So for example, I didn't put a flag next to everything that's Health Canada approved that never spent the money to actually go to HTA and price negotiate. Those things kill me, right? For example, if you look at cemiplimab, first line PD-L1 positive, atezolizumab, first line PD-L1 positive, we had Pembro first line positive. These other companies are like, they've got the market. I'm not even going to attempt to negotiate. So we're not getting companies to come together, and we're not like, how do we fight for best price if we can't get companies to come and get into the ring, right? If you look down here with some of these different agents, again, lorlatinib is just about to come. Lorlatinib's probably gonna triple at least progression-free survival. We're at 5 years and we haven't reached the median yet. And the median with that class of agents sits at around 2 and a bit years. It reduces your risk of brain mets, all this kind of stuff. Huge game changer. They weren't even going to negotiate with them, right? They walked away from PCPA without even starting the conversation. reducing brain mets. Like there's money to be saved if people don't have brain mets. And these are young people who actually still go to work and things like that. Some of these other drugs, we'll see where we land, right? Some of them may not make the bar because they're just not going to be big enough gains. But some of them are, right? So like your Trek drugs and things like that, like we're just starting to see those come through. So like part of where I get stressed is, for example, let's see, it's actually so old, it's not on here. So BRAF agents, right? So BRAF, significant improvements in melanoma, same improvements in lung cancer, but because we didn't randomize, they said they couldn't be sure about the benefit. So therefore they asked for 80% less money than what they give for melanoma, which again, gets my hackles up as a lung cancer treater. I'm like, why does a melanoma person get full price and we have to pay 80% less? But because of that PCPA recommendation or CADITH recommendation, there's now other combinations for BRAF. They're not coming, right? Same thing with MET skipping. First agent goes through, couldn't negotiate a price. Next company said, we're not bothering and coming to Canada. So 100 other upper income countries have access to something that I won't get access to because we don't necessarily think about it the same way. And I absolutely get it, right? Like I want money for lots of things, right? I don't want to wait 6 weeks for a PET scan. I don't want to wait 6 weeks for next generation sequencing. So I'm absolutely like, for example, I would sell immunotherapy back to the Ministry of Health. You can keep it for everybody that I give one of these other drugs for down at the bottom, right? For most of them, they don't work, right? But if you look at the algorithm from something like CCO says, Roz, you can have platinum IO, you can have this, that, and the other, which I don't even want because it doesn't help. And so they're willing to let me spend $100,000 on immunotherapy because the trials didn't know about these other biomarkers when they were done. So they were all in the mix. So they said, well, we can't exclude them because they weren't excluded from the trials. I'm like, I don't want it because the real world evidence says it doesn't work, but then they won't give me my actual targeted drug that works. So there's a lack of ability to have logic about some of these different things. And like, let me trade, right? Like, let me horse trade with you. I will trade you this if you'll trade me that, or silly stuff. Like the government actually requires me to do CAT scans every 2 months for some of these targeted agents based on precedent back to when the first targeted drug in lung cancer was approved. Francis Shepard's trial, BR21, and it showed like a 4-month improvement. Very reasonable to do CAT scans if your improvement's 4 months in progression-free survival, right? Do CAT scans all day long. I now have drugs where, again, the median progression-free survival is 5 years, and yet the line listing says that I have to do CAT scans every 2 months to track this. I'm spending so much resource stupidly on things that I could then be using to other things, but people don't ask. Like, Chris, you do GI? I still can't, like, I still remember my first jump on my soapbox, which was the lack of access to capecitabine. I'm like, you want me to put in a PICC line to give somebody 5-FU and do home care and deal with clots rather than give somebody a pill? This is stupid, but it's because it's 2 different silos and those silos weren't talking to each other. And I'm like, if you just talk to the medical oncologist, they will tell you that this will save you money at the end of the day. But
so lung cancer Canada, are you getting to the point where there's sophisticated and nuanced conversation with the patient community about which drugs they should really push for and march in the streets? Or is it still the narrative, we want more drugs faster, more drugs faster?
it depends on the scenario, right? So we have this conversation all the time, right? Because every company wants us to support their indication. And I will tell you, as the person who leads the group, right? We are very careful about how we word those letters. It's no different than letters of recommendation, right? And I can guarantee you, CADITH can tell the difference, right? Like I will still write a letter dictating the data and da-da-da-da-da. But when it comes to like must have, you got it. Well, so again, we gather from Lung Cancer Canada is probably the most organized of all the patient advocacy groups because we organize the docs across the country to come together. One of us writes the letter, we all bicker about editing it, and then we submit. But we also collect patients. So we will collect patients from across the country. And if we don't have Canadian patients, we'll go to the US, Europe, et cetera, to get the patient voice on toxicities, ability to work, all those types of things to provide that voice. So I think their voice is a little bit different because they're looking at it from a different lens.
Thank you. Anyone else? Any further questions? Let me see if there's anyone.
Oh, I don't see any. Is there one? Oh, okay.
Okay, perfect.
Can you read it out? Because I can't see it.
No, there's
Oh, none. Sorry.
there's no-
Brilliant. Mhm.
Between melanoma versus lung cancer. And the fact that lung cancer does not have RCD and therefore have any HTA body.
Yep.
Do not want to fund for a drug that does not have an MS file.
Yep.
They want to.
Well, they'll fund it if, again, we
Yeah,
pay
it's-
20% of the price.
So is that a fault of the payer? That they don't have a randomized trial lung cancer? Is it a fault of the payer? Should we be blaming the STA bodies and CARET for that? Or should we be blaming the clinical trial ecosystem for not doing the trial?
Yep.
If they had a randomized trial in lung cancer, then probably the CARET would not have asked for any price negotiations like they give for melanoma.
We're starting to try to push more for them, right? Part of the struggle is when you start to get to these biomarker selected subtypes of lung cancer, BRAF lung cancer that actually has the V600E is only about 1.5% of lung cancer. So when you start getting down, even with big brother lung cancer, when you're talking about 1% of the entire population, then you have to think that people who are clinical trial eligible are probably 10% of that. It gets very hard to do these things. So there's that. And then two, the countries that actually force for these different things, and I'm not saying it's wrong to force for these things, get a little bit screwed by the way that the other countries do these things, right? So when the US is happy to bring, they'll approve things on ORR, not to mention PFS, and now Europe isn't that far behind. When I lose Europe and the US as rational sites to be able to actually randomize patients, your ability to do it is zero. So for example, with BRAF, we've been pushing and pushing. And at the end of the day, we're probably never going to have, until they go generic, and if the price goes down, we're not going to see BRAF agents in Canada. We are now past, there's 100 countries across the planet that actually have BRAF funded, and Canada is not one of them. There's not enough lung cancer patients who are fit in countries where we'll accept the data, right? Like Canada won't accept the data from some of these other countries. So that's where it gets hard, is the smarter we get about cancer treatment, you can't do these big trials like they do in breast cancer, where they put 20,000 women in each arm to detect a 0.5% difference between different aromatase inhibitors. That's the hard part with lung cancer, is we've struggled. Even if you look at what should be a big indication, people who get surgery with lung cancer and then adjuvant therapy, doing those big trials requires international partnerships to do non-biomarker selected trials. And that's because of the age of the patient population, the comorbidities that excludes people, et cetera. Now, you should look back at me and say, but Roz, then how do you generalize anything? If, most of your patients can't get onto it, then why do you want these drugs for your patient population? And that's the difference between some of these different things. Like, I don't give immunotherapy to performance status 3 people. I just don't do it. It never goes well. Even though it seems like it should go well, it don't go well. The last time I tried to do that, he got hospitalized with every single cycle of treatment. He's like, we're done. We're done. Targeted therapies are a different beast, right? Like, I had a woman who was on the internal medicine service actually at one of the other hospitals in Hamilton. And I was irked because this woman got booked as a new patient consult into my clinical trials clinic. And so I was like, inpatient in my clinical trials clinic. I'm like, what are you guys doing? She came on a stretcher and I was like, oh, and then I opened up her chart and she had an ALK translocation. I'm like, oh my God. I literally felt guilty that very minute for being grumpy about having this woman show up, because they sent her to me literally with a love note saying, this woman is not accepting of palliative care. Can you please help us? Nobody understood the biomarker report. I looked at him like, I can help you. I can save her. I got her compassionate access to a 1 pill once a day. I had the drug delivered to their pharmacy. They started giving it to her. 2 weeks, she went home. She was bedbound when she started. She went home. She's now walking without a walker. So like, this woman had oxygen, all this kind of stuff. So like, these drugs really work when you give them to patients. And so like, how do you quantify that, right? I'll never forget my first BRAF treated patient. He came to me on a CAD pump on 3 liters of oxygen, and was like followed by community palliative care, had a BRAF mutation. There was a compassionate program, got him drug. This guy, it was so funny. I've never had to negotiate so hard with palliative care to actually decrease the opiates and get him off a pain pump. This guy came off oxygen, came off pain pump, came out of wheelchair. 6 trips between the Caribbean, et cetera, I bought him the 2 years of benefit that he got from agents. How do you quantify that, right? How do you quantify reduced needs of hospitalization, reduced needs of palliative care when these drugs work so efficaciously, twice as efficacious, 3 times, 4 times as efficacious as platinum? I'll stop jumping up and down.
Hello. I'm Zane from Rado. So
Great to see.
I'm not an expert in chemotherapy and systemic agents, but my question is,
I have quoted you in articles and other things. Nice to see you, Chris.
part of the problem that you identified is that if certain medications are funded that you might not prefer as to other medications that are funded are just as expensive or
Yep.
less so. So the person making the decision to fund is either not malleable or able to adjust their decisions, or
Yep.
they're not knowledgeable, or both. So has this been conveyed that maybe the problem is not the decision they made, but how they come to these decisions and alternative models to how these decisions.
I think one of the struggles we have is the evolution of the treatments we've had, right? So if you look back at when these HTA assessments were first brought into play, we were dealing with mostly chemotherapies. Chemotherapies hit a fixed model, right? There's benefit, there's toxicity. There's either overall survival or there's not, right? Done. But as we've moved away to more personalized medicines and things like targeted, I think targeted therapy was the first thing that made it really hard, is all of a sudden has, again, broken different cancers down into these very niche types. And so then, getting robust data on sequencing and what the impact is of having access becomes more challenging. And then you bring immunotherapy to the mix, right? And all the things that we thought we learned from targeted therapy go out the window because progression-free survival doesn't tell the tale with these drugs, but overall survival does. And so all of a sudden, we're now looking at a completely different part of the survival curve. We're looking at landmark analyses and how many people actually probably are cured of their diagnosis, even though it's metastatic disease. I'm sure you guys feel it with radiation a bit, right? It's, how do you show a different technology is useful, right? And I will say radiation oncology, I've got to give my props to my Canadian colleagues, because if I look at the radiation oncology literature, I feel like Canada punches much above its weight at really evaluating technologies before they fully implement them. But it's not the easiest thing on the planet. You have to understand what all the things that you have to take into account.
Okay, we are 5 minutes past 5, so we could be here like longer and longer with more discussions and more questions. It's a very nice talk and very nice discussion. So I would like to thank everyone for coming, and for you who are interested in learning more, Rosalyn will be here tomorrow, 8 in the morning on the next door room for Oncology Grown Browns. Okay, thanks everyone, and have a good evening.
Yeah, I'm